Now we'll start one round of 7 minutes with Ms. Sidhu.
Thank you, Chair. Thank you, Dr. Henderson and Dr. Martin Chazen, coming from Brampton, Dr. Chazen and Dr. Henderson, and your valuable presentation. It is a very impressive and eye-opening presentation. And first questions, Dr. Henderson. Does your organization have a recommendation about how we reduce the regional disparities and gaps for palliative care between urban, rural, and on-reserve regions?
We're actually working right now on some staffing models, and as my colleague here says, part of the problem with trying to develop what human resources are required for palliative care is there aren't any good evidence-based models of how many numbers of people that you have. What is out there starts to talk about, well, here's how many physicians you need, and that's all it looks at. This can't be looked at as a physician resource issue without looking at a whole team approach. And that's the model that we're looking at. You also can't look at it from a purely demographic numbers approach either, which is often how it's done. You need X number of doctors per 100,000 people. Well, 100,000 people in an older part of the country versus, say, Calgary, where you generally have a younger population, that same 100,000 people, when you look at those curves, how many people are over the age of 65? Where are the demands at this time? So we're developing a model that really will be looking at the team approach, how many nurses, how many social workers, pharmacists with extra training in palliative medicine, and palliative care physicians as the specialty team need to be in an area based on really even going back and looking at our death rate, because that tells you how many people, as a better number than just pure population, are needing these kind of services. So we're in the process of working on that right now, but that is something that's very much needed. There's great models across the country showing how this can be done. And again, going right back to Dame Cicely Saunders, who was the founder of the modern hospice movement, she said, this is best delivered by an interdisciplinary team. So having access to that good quality palliative care nurse, I honestly see the palliative care nurse as the key ingredient to this whole mixture, especially for community, rural, urban, everywhere, because you can have more nurses out there working with the primary care teams, physicians, nurse practitioners, and so on, helping to guide them a little bit, but helping to ensure the right assessments are being done, the right information is getting to the primary care team, and when it's more complex, then being able to pull in the palliative care consultant to be able to help with that more of that expertise. So I think that's the way we need to be looking and moving forward. So we are working on that, and hopefully over the next few months we'll have some better, more clear. I know what we need. What I can't tell you yet.
Thank you. Dr. Chazen, I had opportunity to go to the Brampton Civic Hospital where you work, and also toured the geriatric ward. And can you share some of the challenges faced by palliative care unit on the front line at Brampton Civic, which would provide a useful tool to making C-277 and a future national palliative care plan?
Okay, so the international formula, and I know this question was asked, how many hospice beds do you need per population? So the Gomez formula dictates between 8 and 10 hospice beds per 100,000 population. So if we have 1 million people in Brampton, we are looking at a lot more than 10 beds, which is what we have at the moment. There are initiatives at a provincial level to build hospices, but we have the issue of that 54% of patients are dying in acute care hospitals when we don't really want 54% to be dying in acute care hospitals. We have shown that the better the community supports, the more likely the patient is to go home and not bounce back into the emergency room. So I think that's where our issue is. We don't need necessarily only hospices. We probably need some form of a step-down facility where you don't have a physician going in every day, maybe every second or third day, where you don't need one nurse per 3 patients, but maybe one nurse per 5 patients, where you concentrate more on patient care, not just necessarily giving them the medication, where you bring in psychosocial support, which is so poorly lacking. There's very little funding for spiritual support, for psychosocial support. A lot of that funding is being brought in privately, or for people are donating money, and we're raising money from a charitable organization. I think palliative care needs to be brought into the Health Care Act. Hospices really need to be brought in as well, that they're not a separate entity, and that could increase the continuum. We don't need fragmented money coming from different areas. We need one pool, and everybody should be going on along that line.
And as you know, the William Osro Health System recently opened the Peel Memorial Urgent Care Center in the Peel Memorial Center for Integrated Health and Wellness. As we look the way the best provide palliative care, can you speak about those facilities as alternative method for our healthcare delivery? And also, can you elaborate for the home care visit how this model works?
Okay, so I'll start off with a home care visit. We work with nurses, the CCACs, which are now part of the LINS, because it's all at a provincial level. We are making a concerted effort to train as many nurses in that model as possible, going through the LEAP courses and the Pallium courses, which of course raises the standard that we should be measuring. We should have outcome measures of how many nurses qualified through LEAP this past year, how many volunteers, how many physicians have managed to do the LEAP courses. So the nurse-doctor model is the most ideal model. I do think there is a role for nurse practitioners, specifically in areas where there is no physician. I do not think that nurse practitioners need to do this on their own, to take that responsibility, to actually behave like physicians. The job of a nurse and the job of a physician are not the same. So definitely the dyad is the best. In areas where you don't have a physician, then perhaps the nurse practitioner can take on the most responsible person for the patient. The Peel Memorial site is, of course, to get more patients to be able to get more care. There is one of the areas which we as the palliative care physicians will be involved in, and that's a nurse-led clinic looking at patients with chronic medical problems. And one of our goals over there is, if we think that ask the surprise question, which is a gold standard framework question, which is not ours, it's developed in the UK, which, by the way, are the highest country on the quality of death index, where the surprise question is asked when the patient comes into the emergency room. Would you be surprised if this patient would be alive within 1 year? If you would be surprised that the patient would be alive, he needs to have a goals of care discussion. If you're not able to do that, find somebody that can do that. Because perhaps what you think is good for the patient or the family don't really always think is good for the patient. So that's what I would suggest.
Time's up. Mr. Weber.